Good afternoon, everybody. Sorry to disturb you here. We would be more than happy if you stay here and listen to us. My name is Thomas Rösch from Hamburg. I'm here with Brennan Spiegel from UCLA and Alexander Hann from Würzburg. Our topic is virtual reality. And it's a huge topic, actually. So we start with Brennan, because Brennan deals with what I would call the patient journey around endoscopy, during endoscopy, a lot of applications. So if somebody is scheduled for a screening colonoscopy, which offers do you have for him?
Well, so let me start by taking a step back, and then we'll talk about the patient journey. So virtual reality, most people have used it. I'm curious, those of you in the audience, have you used virtual reality before, just by raise of hands? Has anyone used it? Okay, most people here have used it, probably not for colonoscopy, but probably for gaming or entertainment or that sort of thing. And that's true. VR is useful for games, but it turns out it's very helpful for patients too. And so when we have patients coming for endoscopy, we give them the option to use virtual reality during the procedure, particularly for colonoscopy. And we have experiences for them that allows them to achieve relaxation, calm. We might put them in a forest or on a lake or wherever they want to go. And we have breathing exercises that they do in the VR. And we now have evidence that this can reduce propofol requirements and sedation requirements, that patients have less pain and are more satisfied with the experience of endoscopy using virtual reality, especially starting before they come into the room. Even in the pre-op area, we get them started in VR. And so that's how we use virtual reality.
So if they have this helmet type at home, can they get a kind of informed consent already? Or where does the journey start?
Yeah, well, often we'll start the journey by talking with the patient before they even come in for the procedure to let them know we have an alternative approach for managing them. And that way they're prepared for it. Many patients already have a headset, like the Meta Quest is probably the most commonly used headset at home, but there are other headsets. And these headsets have a library, so you can download software. And a lot of this software is free or very inexpensive. And then when they come in, they may have their own headset, or we give them a headset. So we have a VR consult service called the Virtualists.
So they are sitting in the waiting area and can watch any...
Yeah. Well, even when they come in and we put them in the bed and they're getting pre-opt, we'll put the headset on, and we begin playing the music. They listen to the music, and they relax, and we have a breathing exercise. And we also use artificial intelligence, AI, through the software program, and it will measure their heart rate variability, their pupil diameter, and then it'll use biofeedback to change the experience to try and settle their sympathetic nervous system before they go into the procedure.
And they can choose whether they want to listen to Mozart or rap, or do you have special music of which you know it's comforting?
We have a number of different musical pieces that we play, and actually the artificial intelligence, the AI, will often select which music to play based upon the biosensor data. So if somebody is demonstrating a lot of anxiety, their sympathetic nervous system is really firing, their heart rate's going up, their heart rate variability is low, then the computer may select certain musical pieces to try and counter the physiologic stress that they're experiencing, and the visual experience will be selected by the AI. For example, they might go into a Japanese rock garden and relax in that rock garden before until we finally get their their heart rate down and less stress before they go into the room.
So they're sitting in the waiting area, then they're taking the headset off. They're coming into the room.
They keep the headset on.
But they are excluded from the surroundings, aren't they?
So it depends on the headset. Yeah. So there's one headset we use is the Apple Vision Pro. I have no stock in Apple, but Apple has this new computer system, and it's a pass-through, which means they can see all around them in the room. But then we can turn on or turn off depending on how much they're willing to be immersed. Some patients do not want anything on their face at all, and they're probably not going to enjoy this. Other patients will much prefer to have the virtual reality on their face rather than be looking around in the room.
Is there a lot of extra time, or do you save time by that?
Not much extra time at all. Now, we don't require the nurses to do this because they're so busy, and the techs. We have a special virtual reality technician. So they actually clean the headset. We use ultraviolet light to clean it. So just like you have to process scopes, we process the headset, wipe it down, clean it, and then put it on, answer questions, and so that we can address the patient's needs without bothering the nursing staff or the technicians.
And who is responsible for the sedation, and what do you use?
So we use propofol normally, and still we have trainees, our fellows, or whoever's doing the case will use propofol. But in some cases, we don't need to use it at all when they're using the virtual reality. We've had many cases where patients use no sedation at all. And in fact, many patients who don't want sedation, or in some cases, they didn't come with a companion, so there's nobody to bring them home. In those cases, we'll also offer them virtual reality so they can go straight home without any sedation.
So it's a very targeted approach, isn't it?
A very what approach?
A very targeted approach?
Yeah, it's targeted in the sense that it's not for everybody, and there are certain individuals who particularly respond well to VR, particularly patients who have a lot of anxiety, high heart rate, low heart rate variability. Physiologically, we can predict who's going to respond best to VR.
And what percentage of your screening colonoscopies are done with that?
Still not many. This is mostly through research protocols. It depends on our staffing, but we're doing more and more of them now, but it's still a small percentage, less than 10% right now.
But if you would have the ability to roll it out, your guess would be it would be taken up by 30 or 50?
Yeah, we've done some surveys and asked patients about their experiences, and what we have found is most patients like the option of it. They're very satisfied with us thinking differently about how to manage them during the procedure, and the people that go through it find it very satisfying, and that's been demonstrated in various randomized controlled trials now as well. So I would expect that at least 60 to 80% of people would be interested and willing to try it, and that's been our experience in general.
What happens afterwards? The patient wakes up, goes home. Is there any follow-up options?
Yeah, well, we have some software that people can go home with. Now, for endoscopy, the procedure's over, the requirements are over. But for other patients, for example, patients with functional GI disorders or irritable bowel syndrome, where they have long-standing chronic symptoms, we do have an 8-week home-based treatment program that's sort of separate from endoscopy. But we will send them home with a headset, and we monitor them remotely, and they have access to an app which collects data, and then we have access to their progress over the 8-week period.
That's the IBS.
That's for irritable bowel syndrome, yeah.
IBS community.
Yeah, we also, for pancreatitis, we're using it as well. Yeah.
Oh, I see. Okay, if you have any questions, please don't hesitate to interrupt us at any time. So, Brennan, that was the patient, right? What about the poor physician who has to work like 50 years ago without goggles? And any training programs you are aware of?
Yeah, well, and we may talk more about training here. There's a lot of interest in using virtual reality for training. Virtual reality is just a simulation. It's a simulated environment. We're simulating, for example, a lake or a river or some beautiful scene, but we can simulate anything. Can simulate a procedure. So in surgical subspecialties, there's an extensive literature now using virtual reality to train clinicians before they go into the operating room. Just like you don't want your airplane pilot to practice flying your plane without having been in a simulator, it makes sense that surgeons and even endoscopists have practiced simulated procedures and made their mistakes repeatedly in simulated worlds before they go into an actual procedure. That's not how we normally train, though. We see one, do one, teach one, right? That's how we talk about it. But it makes a lot more sense to think about how airplane pilots use simulate. That's virtual reality, too. That's what a pilot simulator, a flight simulator is. So in endoscopy, there was the lecture earlier today of some of the new approaches to combining virtual reality with AI to train endoscopists for how to identify polyps and lesions and how to actually do the procedures. So we're seeing more of this.
In the US, last question to you, is it part of the surgical training or is it voluntary?
This is still mostly voluntary. Now, in orthopedic surgery, we're seeing much more use of virtual reality. And they have simulated devices that they hold, and they even get vibration feedback as they're looking in the headset, and it looks very realistic. And randomized trials have now shown that surgeons who train in the VR experience are faster and more accurate at doing the actual operation. In endoscopy, this is an area of opportunity to do more research to help train our fellows.
Well, area of opportunity, we usually say when we are far behind.
Yes.
So, Alex, that's your term now. What can we do? You have to fill the gap. You have already started, haven't you?
Yes, thank you. So we have a virtual reality simulator for nurses and physicians. So I think one of the charming thing is that you can simulate the endoscopic room, like with everything, with the light, with all the beeping sounds, everything. But you can also simulate this interaction between nurses and physicians. And because we work as a team in this endoscopic room, we should also train as a team. So there are some simulators out there that train like situations in an emergency department. And so we try with Vigatu. We have a booth here, booth number 65, where we can present this. We can train also peri-procedural tasks in the endoscopic room, like filling out the team timeout, like setting up the endoscopic stack, even performing the propofol sedation, with complications even.
Okay, but again, that's a little bit around endoscopy. It's very important, and people tend to neglect it and say, it's not so important, I want to hold the scope. But what do we have for holding the scope?
That's a very good call. To my knowledge, there is no software out there where you can have a scope in virtual reality that you can really do the colonoscopy in VR. There are a lot of simulators where you have a machine and you have a mock-up endoscope and you can insert it and then you simulate the procedure.
Mechanical models.
Exactly, mechanical models.
With a two-dimensional screen, though, right?
Exactly.
Yeah.
But what I think is what does not reflect the real situation is that a lot of things are happening during an endoscopy, like, I don't know, oxygen saturation drops or things like that, and then you have to react, and even react in a stressful situation. And this is those simultaneously happening events can be simulated in VR.
Although I think we should get away from this street musician type of thing. We are scoping, we are sedating, we are doing everything. It's surely important according to our clinical reality. But so how is it working with the surgeons? Do they have their two hands on the laparoscopic instruments?
Yeah, so they'll have two hands on their laparoscopic instruments, and then they're in virtual reality. Yeah. And so the instruments are mock-ups, and they have sensors on them. So they can see in 3 dimensions what's happening in the tissues or within the abdominal cavity, and really can precisely focus the instruments and cut tissue and do also all the parts of their procedure, but completely in a simulated world. And the whole idea of virtual reality is it's a 3-dimensional spatial experience, as opposed to looking at a 2-dimensional screen, which is what we're accustomed to in endoscopy, right? It's a 3-dimensional world conveyed or encoded in a 2 dimensions. So we have a brain that switches 3 to 2D, but in the operating room, everything is really 3D, although when they're looking through an endoscope, it's 2D. But they still have to think, just like we do 3-dimensionally, through a 2-dimensional screen. And so to think spatially requires you to practice spatially. I don't know if you've ever tried using a Da Vinci robot. We never train on Da Vinci robots. I recently tried one just to practice mock-up, and I actually found that it was very easy to use because as an endoscopist, we're so accustomed to looking through cameras and using our fingers to manipulate things in 3 dimensions. And they said, wow, you learned that so quickly. I said, well, that's all we do all the time. So, but it takes years and years of practice to do that. And if you practice in a virtual reality headset, you can very quickly learn to think spatially, and I think there's some opportunities there.
That's reassuring because usually surgeons think endoscopy is very easy and we can do it, but it seems to be the other way around as well.
That's right, that's right.
Okay, but why is it not working or happening in endoscopy? Is it rigid versus flexible, the simulation difficulties?
I think that's a very good question. I think it's maybe also the development costs. So because to build a simulator for for endoscopy is much more complicated, takes much more time, and costs much more than just to, stay as a supervisor next to a person and then teach this person. So this is maybe one of the reasons, but when such a simulator is built, I think it is easy scalable because the VR headsets are not very expensive. The Meta headset, for example, and then you just need the software and maybe some hardware if you want to have a scope in your hand with sensors. But so I think building such a system is pretty complicated.
But is the surgical market so much bigger and they have so much more money?
That's a good question. I don't know why the surgeons are so far ahead, but I think they appreciate the importance of simulation more than we do. I'm not sure why, because we don't use simulators virtually at all. I mean, sometimes we use pigs or, there are example of labs that we do, but we don't normally have our students do that first and demonstrate perfection before we bring them into the endoscopy suite. We just bring them in and go and hope they do well. But in surgery, the stakes are sometimes higher, although they're high with us too. And they're very accustomed to using simulators. So there's a lot of literature. I don't know why, if it's the market's bigger or what it is, but they're much more interested. And there are startup companies that have been successful in the surgical space using virtual reality simulation, and now they're integrating it more and more as part of the curriculum.
Well, when you speak about endoscopy to non-experts, they usually say that's this diagnostic thing. But I think for decades we have been replacing surgery. So it's a good question why it doesn't arrive. So are you working on something for flexible endoscopy, using the scope itself?
Indeed. So because many people told us this is mainly for nurses, peri-procedural tasks. We applied for a new funding and we have now a project where we try to simulate hemostasis and perforation closure with a mock-up scope in your hand or even with your real endoscope with some sensors attached to it. So we just started. It's also a new experience for me because now I have a game designer in my team. So this would be, I'm very curious how this will go on to put in some gamification elements also in the simulator.
I think these guys don't like the manual scope. I've seen a simulation program from Brain Lab in Munich, and they were using their mobile phones, and it was very hard when I talked to them that this is not a scope.
In the end, I mean, it's another controller. So they have controllers for virtual reality, they have controllers for their Xbox or PlayStation, and it's another type of controller.
That's right, but I would prefer to have the manual scope if I have to work with the manual scope afterwards.
Exactly, so if we work together with game developers, they should accept that this is our controller.
There's really no reason we can't use that controller. I mean, I have a controller called a golf club, and I use that golf club to practice golf in virtual reality, and it's extremely effective. I don't know if you play golf, but it's great. So that's a controller. It's called a golf club. We can use a controller that looks and feels like an endoscope and have that as the controller. And as long as it is, connected to sensors that demonstrate accurate changes on the screen, then it can be extremely effective. I guess the problem is looping and some of the pressure and torsion. These kinds of things are a little harder to reproduce without some kind of a box, I guess, that it's connected to.
But I think at least specific therapeutic tasks could be practiced, because what you are talking about are the difficulties of introducing the scope and that kind of stuff, which might be tougher, but to work on a certain polyp with a knife and a grasper or whatsoever might be easier at the end.
Yeah, that's really more about you're already in position. So it's about following the right steps and being able to interpret. And with the other thing is AI. We had an exhibition earlier today in a lecture of AI providing real-time feedback, expert-level feedback, in terms of the visual appearance and where to cut and how to cut and whether the cut is accurate or not. The AI can monitor that and actually give you real-time feedback. So fellows can practice at home, almost like they have an attending with them at home. In fact, you could train the AI and it can sound like your voice, and you can be with your fellows all the time at home. And with virtual reality, they come to work and they're going to be great.
They might want to choose a different voice, but anyway. Okay, that's pretty much at the end of our 20 minutes. I thank you very much. As usual, surgeons are ahead, golfers are ahead, so we have to catch up.
That's right.
Thank you both.
Thank you.
Thank you.